see all sorts of good friends out there, and it's great to be back. I spent a number of hours here, most of which were enjoyable, some of which weren't, depending on what the case was and how it was going. But it really is great to be back. I had the occasion to speak to the first and second year medical students at Emory today. They have a course that they call, I think, Law and Medicine or something like that. And I mentioned that in opening just because I always ask how many of you are interested in going into private practice. I've been doing this now for probably 15 years, 10, 15 years. And how many of you see your ideal situation in terms of your professional life as being somebody else as an employee? And it has, and this will come as no surprise, but the number of medical students now who believe that their ideal practice situation is to be employed. And their ideal practice situation is not necessarily to be in what they perceive in first or second year medical school as being private practice. Has mushroomed to now probably 70 to 80%. None of it's scientific, but there are some scientific studies that have been done that show that about 60 to 65% of medical students, first and second year medical students today across the United States, believe that their ideal position is to be employed by somebody as opposed to running their own shop. That mentality, that shift that has occurred over the last 20, 30 years has, I believe, fundamentally changed how physicians perceive themselves in the workforce and who they believe ultimately they are to be answerable to. All of us ideally want to say that we are answerable to our patients solely. But the fact of the matter is, if one is employed by another entity and that entity actually causes a conflict between what you believe ought to be done for your patients and what the entity desires, then you've got a moral dilemma on your hands. And I would suggest to you that those kinds of moral dilemmas will be increasing over the next 10 to 20 years as opposed to decreasing. Moral dilemmas that aren't necessarily going to be decided on the side of quality health care and patients. I've been asked by so many of you and physicians literally across this land, why don't you just do this for healthcare and you'd solve the problem? And most of the ideas that docs come up with are wonderful ideas. And they would, in fact, solve a certain percentage of the problem as it relates to where we are right now, because the status quo of where we are is unacceptable, clearly. The honest response to all of those questions is a tough one, because it requires compassionate, caring physicians trained in the art and science of medicine, who, depending on what specialty you're in, are significant scientists, or as orthopedists, just faux scientists, to wrap their arms around the answer to that question, which is this whole debate hasn't been about healthcare at all. It's been about power. And I don't say that proudly, but I say that honestly, because the only way that you can get to where we are right now in our nation, in the area of the healthcare debate, with a bill being pushed forward by individuals who have the authority to do so, against the will of the American people repeatedly, the only way we can get to where we are right now and have that still be a possibility after 4 to 6 months of the nation saying, with as much clarity as they can in our system, stop. The only way that can happen is if it is just about power. And so that's where we are, and that's why it's such a challenging discussion to have with physicians, because you know, as well as anybody, or better than anybody, the kinds of things that we could do to actually improve the system. So where are we right now? We have a House bill and a Senate bill that has passed. They passed in different ways, but they include the kinds of things. I guess I should tell you who I am for those of you that I don't know. I've medical school and undergrad at the University of Michigan, trained at Emory. finished residency in 1984 in orthopedic surgery, and opened an office 10, 12 miles north of here, and private practice for 20 years, 20 plus years. Third term in Congress, served on financial services and education and labor, and the senior Republican on the Health Subcommittee of Education and Labor, which is one of the 3 committees of jurisdiction for the health bill. That's the short bio. Senate and House bill both passed. Both of them contain what I describe as the bad 3 things, and those bad 3 things are a government-style program that financially would hold the incentive for employers to move people from private personal insurance to government-provided health insurance. And that's not an opinion. That's a fact. When you see that the government is going to charge 8% for folks to get insured, the average cost for employers out there to provide health insurance for their employees, as many of you know, is between 10 and 14%, 8%, 10 and 14%. When the competitors buying the 8%, you got to go to the 8%, which is why 100+ million individuals in this nation, if these plans were adopted, would be moved to the public plan as opposed to private personal health insurance. That's the first bad thing. Both of the proposals include that, and there are some nuanced differences between the two, but by and large, they're essentially the same. Second bad item is employer and individual mandate. Says to employers, you got to provide health coverage. Says to individuals, you got to purchase health coverage. And on the face, that doesn't sound terrible because you say, well, people are got to be covered, right? But what happens when Congress mandates something is that it defines what it's mandating. And in this instance, it defines what qualifies as health coverage, which is where you get into the, if you like what you have, you can keep it. And nothing literally fits with the definition of what would qualify as health coverage. It's a soup to nuts. It is not a bare bones policy. So much so, excuse me, that the Federal Employee Health Benefits Program, if Congress were subjected to the plan, which didn't pass in committee, but the Federal Employee Health Benefits Program doesn't comply with the health coverage that's defined in the bill. So health savings accounts, medical savings accounts, high deductible catastrophic plans, cafeteria plans, all those things that literally millions of Americans use would not only be unavailable, they'd be illegal to sell in the United States. That's how drastic the mandated portion of the bills are. So, and both of the plans include individual and employer mandates in some nuanced way. And third and finally, and maybe most oppressive to you, is that they both, I believe, cede the definition of quality health care to the federal government. Meaning that the Comparative Effectiveness Research Council and the Health Commission's committee would be the determining factor in whether or not you would be able to do X, Y, Z for your patient. And if you didn't believe it before, the recommendation that came out 2 months ago that screening mammography for women under the age of 50 wasn't necessary to screen for breast cancer. That entity is the one that would be recommending to the Comparative Effectiveness Research Council that would be determining what coverage would be included in the plan for the 100+ million Americans who would be in the plan. And everybody went, oh, no, you can't have that, right? Because, got some bureaucrat up there making that decision. So everybody that voted for the plan ran around as rapidly as they could to pass a piece of legislation that said, oh, no, you got to be able to cover screening mammography. So the take-home message in that is not what the diagnosis was or what the test was. It was that politicians think that they can make clinical decisions. That's the take-home message, right? Because we ran around making a clinical decision about whether or not you ought to be able to order a screening mammogram for women under the age of 50. That's insanity. You think about the scope of practice and the mandated benefits challenges that we've had at the state level. All of those would get transferred to Washington. And I promise you, that's not a warm and fuzzy place to be to answer all of those questions. So the 3 bad things, the big bad things in these bills are the government program, pushing people into the government program, the mandates, and the ceding of the definition of quality to the federal government. Now, what about the whole issue of SGR and physician reimbursement? As Paul mentioned, that, as you know, has been in place now about 13, 14 years. It is a terribly flawed formula. Sustainable growth rate which is neither sustainable nor growing and hasn't been since the day it was passed. And on track for a decrease of 21%, was at the first of the year, and then bumped for 2 months, and now bumped for another month. And likely what will happen is that some type of plug will occur either through the end of September, the fiscal year, the end of this fiscal year, or through the end of December. From a political standpoint, I can't imagine why they would not want to solve this problem through the election, the folks in charge right now, except that I believe that they and our leadership in the past have used physicians as a political football, or a political yo-yo to keep the docs coming back to Washington and begging and begging and begging. And clearly, I don't know how many of you are members of the AMA, but it doesn't make any difference. In Washington, the AMA is kind of seen as the medical entity that represents physicians. And the AMA sold their soul, I believe, on the SGR last June when it agreed to a bill that they haven't seen yet in exchange for the fix for the SGR. And clearly the fix for the SGR never came, but they're still, running after the train saying, hey, how do I get on now? So, and that's what both sides of the aisle have done to docs. And it's unconscionable. It's unconscionable. The fix for the SGR, I believe, to be two things. One, in a transition phase, Medical Economic Index, MEI, which actually accounts for what it costs to provide the care, and then has a cost plus, and then a move to an ability for you to contract with patients and have a balanced billing opportunity, so that whatever the federal government is going to pay you for services ought to be a payment, but not a reimbursement. This notion that the federal government ought to be setting your prices is just, it has all sorts of unintended or intended consequences that are disruptive to the physician-patient relationship. So if the federal government wants to pay you $1,000 for X, that doesn't mean that that's what you have to accept or all that you can accept. Once you stop that craziness, then you can get off of the bandwagon or off of the wagon of having the insurance companies track everything to the federal government fee schedule. So you got to be able to balance bill. We've got a couple pieces of legislation that would do that. I think that's where we need to get in order to allow physicians to truly be able to contract separately and independently and freely with patients. What's going to happen in the next 3 weeks? It's going to be a bouncy 3 weeks from a political standpoint. The president has laid down the gauntlet and said he wants the bill out of the House by the 18th. The problem with all of this is the House, in order for the reconciliation process to occur, the House has to pass the Senate bill as it passed the Senate, which includes abortion language that a lot of folks in the House don't like, including Bart Stupak and 12 members of the Democrat caucus who only voted for the bill because it got in his pro-life language. It includes the Cornhusker kickback, the thing that Senator Nelson got in from Nebraska. It includes the Louisiana Purchase, the thing that Senator Landrieu got in. God bless Senator Landrieu from Louisiana. You know, she was accused of selling her vote for $100 million. And she went down, called a press conference, and everybody thought she was going to say, that's not, I'm not going to do that at all. And she did. She said, I'm not going to do that at all. I wouldn't sell it for $100 million. In fact, I sold it for $300 million. That's not the language she used, but that's what happened. And the Senate bill, and it includes that $300 million. And it includes the Gatorade provision, the exemption of the Medicare Advantage programs for Florida, but not for the rest of the nation. So tax increases of about a half a trillion dollars, $500 billion, and decreases to Medicare of another $500 billion. You ought not be comforted by those decreases to Medicare. $350 billion of those decreases are through fraud and waste and abuse. And though you and I know that the fraud in Medicare is by and large people stealing your number and stealing a patient number and setting up a window storefront somewhere and billing until Medicare figures out what they're doing, which oftentimes is 6 months or more. They believe, Medicare believes, and I know they do because they've increased the number of inspectors that are coming and looking at you. They believe that the fraud is in the practice of medicine, which is just a bunch of bunk. And so that $350 billion has to be extracted from your hide, not from the folks down on whatever street it is where they run storefronts practicing or just sending out bills. So, as I said, the president has said the 18th is when it needs to pass. I don't think it can get there in the House by then. I think that their plan, Speaker Pelosi's plan, is to try to get something done before the Easter break. We've got 3 weeks to go before the Easter break. If it's not done by then, I don't think it gets done this year. That being said, I have been quoted as saying if it didn't get done by the 1st of February, I don't think it gets done this year. If it doesn't get done by the 1st of March, I don't think it gets done this year. Because we are about to be in political season. The Illinois primary has already occurred, the Texas primary has already occurred, and as soon as you get into April and May, the primary season gets very robust. And I know this will come as a grand surprise, but politicians are risk averse. The last thing they want to do is anything that gains great attention to them during the heat of a political campaign. And the American people have spoken loudly about these two bills, 2 or 3 to 1 against them. And so the last thing somebody wants to do 2, 3 weeks, 4 weeks before somebody's going to the polls to vote for or against them is to do something that is against what the majority of people in their district want. So next 3 weeks will be the time period. Going to be very, very challenging to get done. That's not to say that something doesn't need to get done because, as I mentioned early on, status quo is unacceptable. There are positive solutions out there. Let me review what we put on the table, and then I'll be happy to open it up to questions. H.R. 3400 is a positive piece of legislation that solves the challenges that we've got without putting the government in charge and without spending one more tax dollar. First, I want to mention 4 specific things. One, you got to get folks covered. Can't have folks, tens of millions of people walking around out there without health insurance. The way that you do that as a good conservative is to make it so that it's financially feasible and attractive and foolish for anybody not to be covered. You do that through the tax code. Deductions, credits, advanceable credits, refundable advanceable credits, all the kinds of things that make it so that every single American at the end of the day sits down and does their budget. Or if they do their budget, they say, oh look, it makes more sense for us to have our health insurance financially than not. And Americans are bright folks. They'll make those decisions over a period of time and move toward getting insured when it makes financial sense. Secondly, you got to solve the issue, the true challenges of insurance, especially portability and pre-existing. You ought not lose your insurance if you change your job or you lose your job. That's the portability issue. You ought to be able to take your insurance with you. You ought to be able to own your insurance regardless of who's paying for it. And the pre-existing challenge, you ought not be priced out of the market if you have an awful diagnosis or an awful injury. The way that you do that is to make it so that individuals can pool together literally with millions of other Americans. So you get the insurance to do what it's supposed to do, which is to spread the risk, decrease the cost, and then you make it financially feasible for folks to do so. Third, and sadly, we need to write into law, I believe, write into law that physicians and patients and families are the ones that make medical decisions. All of these bills usurp that ability and that authority. And nobody says they want to do that, but that's what the pieces of legislation do. So I believe that you got to now in this nation write into law that patients and families and doctors are the ones making medical decisions, and you can't override that. And then finally, you can't be serious about any of this stuff if you're not serious about lawsuit abuse reform. The whole challenge of malpractice and the practice of defensive medicine. Gallup came out with a study a week or 2 ago that said that 1 out of every $4, 25% of the healthcare dollar goes to the practice of defensive medicine. That's $650 billion. Now, I don't know whether it's that much, but say that they're wrong by a factor of 2. Say it's just $325 billion. That's still huge, huge money that could be utilized in a much more effective way to provide appropriate health care for America. So H.R. 3400 is the bill. If we can ever answer any questions or be of assistance to you in any way, don't hesitate to shout. We're as close as your phone or your computer. I'm just Tom Price at mail.house.gov, and we'll get that to Paul and he can circulate it around. In the end, thanks for what you're doing. I know it's not easy. It is incredibly challenging right now to take care of patients, and I know that. And I just want to commend you for sticking with it. There are a lot of forces out there that would say, you know, give it up, give it up, give it up. And I hope that there's nobody here who believes that they just ought to throw up their hands and say, oh, let them have it, because it can't be any worse than it is right now. It can be a lot worse than it is right now, I promise you. So thanks thanks for what you're doing, and I appreciate the opportunity with you today.